Your liver can be storing fat, quietly inflaming, and laying down scar tissue, and you will feel nothing. Not tired, not sore, nothing. In the United States, about 32% of adults have it. Roughly 19 in 20 do not know. Here is what the evidence says actually reverses it, and which part of it barely moves at all. This is prime health. Last time I promised you the liver, why fatty liver is usually silent, how it actually gets found, and what the evidence says can change it. So, first, why you feel nothing. Then what it costs you, which is not the part most people worry about. Then how it is actually found, because the test you are probably thinking of misses most of it. And then what genuinely moves it. Chapter 1, the silence. Start with how common this is because it changes how you should read everything after it. A review of 92 studies covering more than 9 million people put the global prevalence at 30%. In the United States, a national survey that actually scanned 1,299 adults measured 31.9%. That is not a rare disease. That is closer to a coin flip in a waiting room. So why does nobody feel it? Because the liver has almost no pain fibers inside it. And because fat, inflammation, and scarring do not interrupt what it does until very late. The National Institute of Diabetes and Digestive and Kidney Diseases puts it plainly. Usually, it is a silent disease with few or no symptoms. And then the line that should stop you, you may not have symptoms even if you develop cirrhosis. Which is why the awareness numbers look the way they do. In a national survey of people with suspected fatty liver, 90% had seen a healthcare provider at least once in the past year. Only 5.1% knew they had it. Read those two numbers together. This is not mostly a story about people avoiding doctors. It is a story about a condition that does not announce itself in the room. One naming note, because it will save you confusion when you go reading. In 2023, 3 international liver societies renamed this. Non-alcoholic fatty liver disease became metabolic dysfunction-associated steatotic liver disease, or MASLD. Part of the reason was blunt. In the survey behind the change, 61% of experts said the word non-alcoholic was stigmatizing, and 66% said the same about the word fatty. Most of the research I am about to quote was published under the old name. Chapter 2, what it actually costs. Stage 1 is the fat itself. Fat gets into liver cells faster than the liver clears it, and once more than 5% of those cells are loaded, it counts as fatty liver. This is the stage everybody pictures, and on its own, in most people, it is the least dangerous part of the whole story. Stage 2 is inflammation. In some people, and we still cannot reliably predict who, the loaded cells become injured, the immune system arrives, and the condition earns a second name, steatohepatitis. This is where the liver starts taking real damage rather than just storing something. Stage 3 is scarring. Fibrosis. Repeated injury makes the liver lay down fibrous bands between its working units, and the tissue stiffens. Push that far enough and you reach cirrhosis, where the architecture itself is rebuilt. 4 stages. And here's the part that surprises most people. Of those 4 stages, the one that predicts whether you die of this is not the fat, and it is not the inflammation. It is the scarring. 619 patients were followed for a median of 12.6 years. Compared with no fibrosis, Stage 1 carried a hazard ratio of 1.88, Stage 2, 2.89, Stage 3, 3.76, Stage 4, 10.9. And the study's own conclusion was that fibrosis stage and no other feature of steatohepatitis independently predicted long-term mortality. Though it is worth being precise about what people with this condition actually die of. The American guidance says the most common causes of death are cardiovascular disease and cancers outside the liver, and that liver disease comes after both. So this is not only a liver story, it sits inside the same metabolic picture as your blood pressure and your blood sugar. Chapter 3, how it actually gets found. Here's the thing almost nobody is told. The blood test you are picturing, the liver enzyme, ALT, does not rule this out. in a national survey that scanned people rather than waiting for them to be referred, using the standard cutoffs. A normal ALT missed 70% of the men who had it and 71.2% of the women. The American guidance says it directly. Enzyme levels are frequently normal in patients with advanced liver disease and should not be used on their own to exclude it. And there is a second problem underneath the first. The reference range your lab prints is not the range this disease is judged against. The guidance puts a true normal ALT at 29 to 33 units per liter in men and 19 to 25 in women. Plenty of labs still flag nothing until it is well past that. So a result inside the printed range is not the reassurance it reads as. What about a scan then? This is the genuinely counterintuitive one. On ordinary ultrasound, the American guidance does not recommend it as the tool to find fatty liver because its sensitivity is too low across the range of the disease. It will often see a badly fatty liver. It is not reliable at finding the earlier ones. So what is recommended? A score you can already calculate from tests you have probably had. It is called FIB4, and it uses 4 things: your age, 2 enzymes, and your platelet count. Under 1.3 is low risk, and the guidance says that result is good at ruling advanced scarring out. Between 1.3 and 267 is the middle. Above 267 is high risk, and that is a referral. With 3 honest caveats. Over 65, the guidance raises the low cutoff to 2.0 because age is in the formula and it drags older results upward. Under 35, it says the score has low accuracy and it should not be used when someone is acutely ill. A single number that is cheap and useful is not the same as a number that is right for everybody. If the score comes back in the middle or high, the usual next step is an elastography scan, which measures how stiff the liver is. Under 8 kilopascals is used to rule advanced scarring out. Between 8 and 12 is the gray zone. Above 12, the guidance says a high likelihood of advanced fibrosis. And in the same sentence, it says the positive predictive value there is low, between 0.34 and 0.71, which means above 12 is a reason to look further, not a diagnosis. And who should be looking at all of this? The European guidance names 3 groups: people with type 2 diabetes, people with abdominal obesity, plus at least one other metabolic risk factor, and people with abnormal liver tests. The American guidance is equally clear in the other direction. It does not advise screening the general population. Both of those belong in the same breath. Chapter 4, what actually moves it? Weight loss is the intervention with the most evidence behind it, and the guidelines put numbers on it. The 2024 European guideline recommends a sustained reduction of at least 5% to reduce liver fat, 7 to 10% to improve inflammation, and at least 10% to improve fibrosis. The American guidance from 2023 draws it with 2 rungs rather than 3. 3 to 5% improves the fat, and more than 10% is generally needed to improve steatohepatitis and fibrosis. They agree on the shape, the scarring is the expensive rung. The trial underneath those numbers followed 293 people with biopsy-proven steatohepatitis for 52 weeks and took a second biopsy. Sorted by how much weight they lost, steatohepatitis resolved in 10% of those who lost under 5% of their body weight, 26% at 5 to 7, 64% at 7 to 10, and 90% of those who lost 10% or more. And then look at the scarring row because it does something different. 16%, 18%, 16%, and then 45. Now the number that keeps that honest, and it is in the same table. Of those 293 people, only 30% reached 5% weight loss at all, and only 29 of them, about 1 in 10, reached 10%. So the 90% figure is real, and it describes what happened to 29 people who got somewhere most of the group did not get to. Both halves of that are the finding. And when you pool the randomized trials rather than one cohort, the picture gets more sober still. 22 randomized trials, 2,588 people, median 6 months. Liver enzymes improved, liver fat improved, fibrosis did not move, the pooled estimate crossed 0. 6 months of ordinary weight loss programs is enough to shift the fat. It is not, on this evidence, enough to shift the scarring. Which brings me to the finding I think is most underrated in this whole area. Exercise reduces liver fat, even when body weight barely changes. 14 randomized trials, 551 people, liver fat measured by MRI. People in the exercise arms were about 3.5 times more likely to reach a 30% reduction in liver fat. 34% of them did, against 13% of controls. And the authors note that no trial in the analysis reached the weight loss usually considered necessary. Average weight change was 2.8%. The dose that keeps coming up is the ordinary one. A 2023 expert roundtable recommends at least 150 minutes a week of moderate activity, or 75 of vigorous, for everyone with this condition, and states that the benefits show up without clinically significant weight loss. Head-to-head, aerobic and resistance training reduce liver fat about equally. Resistance work gets there at meaningfully lower energy expenditure, which matters if aerobic exercise is hard for you. And more was not better. A trial that randomized 4 different doses found no difference between them. On what to eat, the American guidance is refreshingly unromantic. Low carbohydrate against low fat, saturated against unsaturated intermittent fasting. Mediterranean, it says they appear comparable in their ability to improve the condition. What does have specific evidence against it is sugar-sweetened drinks. The European guideline recommends avoiding them outright, and the American guidance says excessive fructose raises the risk of fatty liver, steatohepatitis, and advanced fibrosis independently of calories. So, the diet you can actually keep minus the drinks. And alcohol briefly because it interacts. The American guidance says obesity and alcohol raise the risk of liver injury synergistically, and that anyone with clinically significant fibrosis should abstain completely. The European guideline says the same for advanced fibrosis or cirrhosis at 100% panel consensus. It also says the evidence does not support the idea that light drinking protects you. One last honest note on what happens if the weight comes back. The evidence is genuinely mixed, and I would rather tell you that than pick a side. In pooled trial data, every kilogram regained tracked with worsening disease activity. In a 10-year cohort of 1,160 men, about half saw it return, and regain of just 1.5 kilograms marked the threshold. But an MRI study followed people 2 years past a diet and found the liver fat improvement had held, even though the weight had partly come back. So, worth defending, not proven to vanish overnight. So, the short version. Fatty liver is common, it is usually silent, and a normal enzyme result does not rule it out. Of the 4 stages, scarring is the one that tracks with mortality, and it is also the hardest one to move. Weight loss of 5 to 10% has the best evidence, with the honest caveat that most people in the best trial did not reach it. Exercise helps even when the scale does not. Skip the sugary drinks, keep the diet you can actually keep, and if you have diabetes or abnormal liver tests, the FIB4 score is a cheap place to start a conversation. If this was useful, subscribe. Next time, insulin resistance. What it actually is, how it is measured, and which of the everyday advice about it holds up. This channel is education, not medical advice, and this episode is about a condition that needs a real diagnosis. If any of this sounded like you, that is a conversation with your doctor and a blood test, not a decision to make from a video. I am an AI presenter, and everything here is drawn from the sources on screen. Thanks for watching.